10% per student.
Oh, come on, that is.
so happy. Yes, to. So today I presented the meeting, the case to the meeting, to our all the urology staff, because at this time it's here 10 a.m. and everybody's in the OR. So,
Good.
but I received some questions that I wanted also to share. They asked me to share with the group, but I am very happy to share this case that,
Wonderful.
of course, that we humbly give some suggestions and advice.
Wonderful. Okay, the only thing is once we start the meeting, everybody has to mute the microphone and we just connect when we are speaking. Otherwise, there is too much echo. So I'm going to mute mine too.
Okay.
Dr. Bischoff, I'm having some difficulty finding Dr. Yamalt for case 5. I've sent a number of emails and haven't really heard anything back in a text.
That's fine. I think I knew this possibility, so we have another case 5 and I'm happy to present instead of case.
We'll still keep looking. We'll still keep hunting him down.
Perfect.
Good morning, Luis. You can set up your webcam and microphone now.
Yes, thank you.
Here we go.
Thanks so much.
Greetings, everyone. We'll be starting in about 2 minutes.
Good morning, everyone, and welcome to our International Colorectal Web Meeting. Today we have pediatric surgeons joining from Costa Rica, Peru, Dominican Republic, Colombia, Bangladesh, Russia, Haiti, Thailand, Greece, Kenya, Argentina, Sri Lanka, Philippines, Indonesia, Bahrain, India, Nigeria, United States, Italy, Egypt, and Spain. If I missed your country, please type in the chat, and in the end, we will acknowledge again. Just a few reminders: if you're not presenting and speaking, please mute your microphone. Otherwise, we all hear a lot of echo. So our first presenter is our current pediatric colorectal fellow, Dr. Leah Wehrle. Leah, welcome.
So good morning, everyone. Thank you very much for the opportunity to present. I will start with one case, number one. It's a 7-year-old female who was born and operated on due to a rectoperineal fistula in the newborn period. So she had an anorectal malformation with a perineal fistula. In her chart, it was noted that she had a urethral, bladder, and a vaginal duplication. Now, she comes to you, and at the age of 7 years, due to persistent stool accidents. So she was having daily bowel movements, what the parents said, but she also had a lot of stool accidents, so smearing in her underwear. Now, what would your next steps be in evaluation of this patient? What kind of diagnostics would you do? Would you do an abdominal X-ray to look for stool burden? Would you do a contrast enema? And would you do an exam under anesthesia? So we'll leave the poll running, and I see about equal 9, 10, 11. Yeah. So the majority of you are going for all of the above, which what we also did. We got an abdominal X-ray which showed a very high stool burden throughout her colon and especially in her pelvis area. We did a contrast enema. Here you see the lateral and the AP view, which showed this very large dilated distal colon and rectum. And we also did an exam under anesthesia, especially to evaluate, since it was noted in her chart that she had a double urethra, double bladder, and vaginal duplication. So here you can see the image of her exam under anesthesia, which shows two Foley's in her one left urethra and right urethra. And you can see two vaginal openings. We then took the patient to do a cystoscopy. So we intubated the right as well as the left urethra with the cystoscope, and she had two separated bladders. So one right, one left bladder, which were each containing one urethral opening. So urethral opening. So one opening from the urethra, from the kidney, from above. We then examined her vaginal opening. She had, while doing the vaginoscopy, she had two cervixes, but she had only one vagina. Seeing here, we went with the clamp underneath the hymen, and it is a septated hymen. So the final diagnosis from our exam under anesthesia with the contrast enema and the abdominal X-ray, that this patient was corrected or underwent in the prenatal, postnatal episode that she had a rectoperineal fistula with severe constipation and pseudofecal incontinence. She has bladder and urethral duplication. She has double cervices and a uretary didelphys, but only one vagina with a septated hymen. Now, what is the difference between a hymen versus a vaginal septum? One, a hymenal septum is an incomplete perforation of the hymen. Number two, vaginal septum can be either longitudinal or transverse, or both, so meaning both statements from the above are correct, so all of the above. What do you think? Hello?
The whole screen is not working on this one for some reason. I apologize.
That's fine. So let me just reveal the solution. So they are both statements are correct. So the hymenal septum is an incomplete perforation of the hymen. It can be there can be multiple orifices, or as in this case, two orifices. The vaginal septum can be either way, longitudinal or transverse. Next question. What are the possibilities for associated malformations of the urogenital tract in patients with anorectal malformations? Do you think from all the patients with anorectal malformation, in 30% these patients have urogenital tract associated malformation? 50%, 70%, or even 90%? What do you think? Okay, I'm impressed. I thought that's a hard question. The majority of you answered 50%, which is correct. So 50% of patients with anorectal malformations do have associated malformations of the urogenital tract. What operative planning would you consider for her bladder and urethral duplication? Would you resect one of the urethras? You wouldn't do any further surgical treatment and would say, leave it alone? Or would you surgically resect one of the bladders and reimplant of the then resected urethra to the other side? Again, the majority of you answered this question correct. No further surgical treatment. I actually didn't give you the hint side, but the patient is having urinary control. So no further surgical treatment is needed or recommended. So again, this is the image that she had while performing the exam under anesthesia. And what we did, we resected the septum of the hymen with cautery and then oversaw the edges with micro-rapid. And that's how it looked at the end of the operation. So thank you very much. That was my case.
Thank you very much, Leah. If anybody has any questions or comments, just please type on the chat. I think it's always interesting when we find a patient with urethral and bladder duplication. Those are not very common, but as Leah presented, if the patient has urinary control, nothing should be done. Just to clarify a few things, I'm happy on how everyone answered, but generally speaking, patients with anorectal malformation, they have 50% associated urological anomalies. And then regarding duplication of the Müllerian structures, meaning vaginal septum, 2 hemivaginas and 2 hemiuteri, It happens in about 1% in patients with rectoperineal fistula, 5% in patients with rectovestibular fistula, but 60% in patients with cloaca. So the majority of patients with cloaca will have 2 hemiuterus and 2 hemivaginas. There is a question about what type of bowel management did you use for the stool burden and pseudo incontinence? That's a very good question. Leah, do you want to answer?
Yeah, so while having her under anesthesia, we did a fecal disimpaction. So we manually removed the stool. And then we started with enemas. And after that, we transitioned her to Senna. So X-lax or, yeah, X-lax with the daily bowel movement.
So usually for patients that have good prognosis for bowel control, we manage them with laxatives, but we always disimpact them first. So once they are disimpacted, then we start the protocol with Senna. You want to comment?
Yes. The first piece of information that we need in a patient with such a severe mega rectosigmoid is what was the caliber of the anus. Because when patients with perineal fistulas, ironically, the lower the malformation, the simpler the malformation, the more severe the constipation. So it is probably that this patient had a normal size anus. But if it turns out that the patient had a stricture, then the treatment would be operation of the stricture first. Assuming that the caliber of the anus was normal in this patient, then as it was mentioned already, we have to disimpact the patient, and then we have to determine if the incontinence of the patient is true incontinence or is pseudo incontinence. By the way, we also need information of the quality of the sacrum in the patient. Because chances are some patients may have a severely defective sacrum. Assuming that this sacrum was normal, then we have to assume also that most likely this is pseudo-incontinence. But we have to demonstrate that it's pseudo-incontinence. How do we do it? We clean the colon first, and then we administer laxatives. But nobody knows how much laxative the patient needs. We have to determine the amount of laxative specifically different for every patient. And we do that over a period of 1 week, giving increasing amounts of laxatives and seeing the response of the patients and taking X-ray films every day. We give X amount of laxatives, and if the patient doesn't poop for 24 hours, then that means he needs an enema and increase the amount of laxatives and keep going that way until the patient passes stool. And then the question is, did he pass stool in the toilet or in the underwear? If he passed the stool in the underwear, then that patient has really incontinence and cannot be treated with laxatives, needs an enema every day. But if the patient was able to pass stool but in the toilet, then the patient actually suffers from pseudo-incontinence and can be managed with laxatives, and he's going to be very happy.
Any other questions, concerns, comments? If not, we're gonna thank you very much, Dr. Weirley, and we're gonna move to the second case that will be presented by our past pediatric colorectal fellow, that is Dr. Cynthia Galvez. Welcome, Cynthia.
Yes, good morning, Dr. Bishop. Good morning, Dr. Peña. Good morning, also Dr. Luis. Thank you for this nice introduction. Thank you so much. Always in my heart. So please, in this opportunity, in name of the team of the urology here and pediatric surgeons at Jody Mayo Children's Hospital, let me present the case of anorectal malformation of rectourethral fistula and normal anus. Let me go ahead. So this is a 2-year-old boy born with 37 weeks, and immediately after he born, the nurses start to observe that he's presenting a stool coming out through this urethra that is located just in the base of the penis. So we call it penoscrotal hypospadia. As a prenatal, the patient has a single right kidney. This is the physical exam of the patient of the area of the perineum, and we can observe apparently a normal anus. Beside of this, the patient also have been presenting ventricular septum defect, hemivertebras in T4, T10, no tetrachord, and also he has hydronephrosis of the right kidney with megaureter and agenesis of the left kidney. The patient was born in Toronto, Canada, and over there immediately the doctors did in the postoperative, in the day of life 3, colostomy and vesicostomy. Then the patient, for family reason, they moved here to United States and came to Miami. And here in Judy Mayo, we perform a distant colostogram that we can appreciate the contrast coming out through the connection with the urethra. Yes, so here, so the patient have been evaluated for pediatric surgery here and also for urology, and we underwent to a cystoscopy when at the beginning we have been observing a bladder, but then just below of the bladder neck we saw an orifice that is apparently is the connection of, or the insertion of the distal ureter just immediately below of the bladder neck. So here we see this is the bladder and just immediately below of the bladder neck. So it's a ectopic insertion of the right ureter. And then if we move our attention toward the contrast study, so we injected contrast and we were able to visualize all the contrast going retrograde fashion to the kidney. And also we can observe so the dilatation of all the ureters. So here and then we move our cystoscope outside and we will appreciate that there is the fistula. So this is the urethra and this is the nodal connection, there is the fistula, and just this is divided for a very thin membrane. The connection was just below of the verum montanus. So you can go here. It's just this, the verum montanus. Here we can appreciate the verum montanus, we just was below. And also, we injected contrast through there, and we were able to appreciate the contrast going up and then coming out through the distal orifice of the colostomy. Immediately after do this procedure, pediatric surgery perform a penia stimulator of the anus that we observe very good contraction. And then we started to perform the anoscopy.
We have a little delay. We'll get that. It's coming up now. Hold on.
Yes. So we, and then we injected also contrast to the anus, and we can see that there is regular length of the, we may call distal rectum, that we have been observing in our patient. So here is the Colosto Dianoscopy, and we can see the wall of the rectum, also the presence of mucus. We were trying to find any fistula or connection from there to the urological system, but no, we came just below the mucus, and we did not observe any fistulas. That also we confirmed with the contrast study. Perfect. So at the end, we make a lecalidographic representation of our patient. So he has a sigmoid colostomy, and then the distal colostomy, there is a connection of recto-urethral fistula, and also a single kidney, right kidney, a very dilated ureter, and with a ectoper insertion of this ureter just below of the bladder neck, a hypospedia, panoscrotal hypospedias, and a anus was able to pass a Hegar number 10 and approximately 6-7 centimeters of length. We brought this case to this group just humbly to have some suggestions in regarding how questions like, for example, how we should approach this, if we should bring the distal rectum, divide this fistula and connect with this remnant of this distal rectum, and also should we do in the first surgery when we do this insertion also the reimplantation of the ureter, how you will approach this to repair this fistula. And also today in the group they have been asking me if we should still do a rectal biopsy to rule out Hirschsprung disease. Thank you. Thank you so much.
Thank you very much, Cynthia, for a wonderful presentation, and most importantly, for the beautiful diagram. I think whenever we are discussing complex anatomy, having a drawing helps a lot, so we all can visualize the same anatomy. So the first question is, how do we call this anomaly? We usually say those are complex malformations because those are rare cases. One is never exactly like the other. So we like to say those are complex anomalies. And yes, you must preserve the anus because that's the chance for this patient to have bowel control. So how do you approach those cases? We normally recommend opening posterior sagittal transanerectum, meaning you're gonna split this rectum in the middle like a book, so you can dissect the rectal urethral fistula, and then you're gonna have to reconstruct and you will end up with a T anastomosis. So it's very important to keep the colostomy so the patient does not have a stricture. And it's important to remember that the dilation in this case will be very high. You wanna make sure you are dilating the anastomosis when the time comes. So it's important that whoever does the anastomosis know how deep it is, so you can teach the mother properly how to do it. It's very concerning that this patient has one single kidney, reflux, and that the ureter is below the bladder neck. This is very concerning about the future urological function for this patient. So I think a reimplantation, leave the vesicostomy since the patient has one, to make sure that this reimplantation is working, that this kidney is decompressed, because this is a high-risk patient for future need of kidney transplant. So it's very important to follow the kidney function very strict. I think those are my comments. Do you want to comment?
The main problem of this patient probably is going to be the urologic problem, the nephrologic problem, because our experience with ectopic ureters, when the ureters are implanted in an ectopic fashion, usually the kidney is severely damaged. Even if a baby has a normal creatinine at birth, when they have growth spurts, when they, like puberty, that's when it becomes obvious that the kidney functional reserve is limited. So the urgent in this patient is to protect the kidney. One way would be to separate the ureter from the ectopic location and reimplant it, provided the vesicostomy is really working very well. In other words, we have to guarantee that that mega ureter is draining. If there is a problem, the patient may need a ureterostomy in order to evaluate how much function that kidney has. Ideally, will be a reimplantation and with a good function vesicostomy to decompress the kidney. That would be number one. Now, concerning the separation of the rectum from the urethra, in your diagram is not very clear whether the lower rectum, the little piece of rectum that the patient has, interferes with the posterior saxal approach to separate the rectum from the urethra. If it interferes, I agree with Dr. Bishop, we have to open transanorrectally, divide the rectum in two halves, which is a delicate, sophisticated operation, being sure that when you bring together both halves of the rectum, you do it in a very precise manner. And then you, of course, you have to anastomose the rectum, the upper rectum to the lower one. And I think that's as much as I can say. If the sacrum is normal, this patient could have bowel control, and that's the good news, of course. And then the reconstruction of the perineal hypospadias, that's a challenge because we have not found the ideal tissue replacement for urethral tissue, and perineal hypospadias continue being a little bit of a challenge.
So there is a question, can the PSARP be done primarily? I'm not sure I understood this question. The person is saying doing it without a stoma. I would say in a case like that, it's very risky. If the surgeon could bring the ureter instead of the distal rectum. So I think this is not a case for a primary PSARP without a colostomy, especially if you're gonna do this anastomosis, that it's gonna be very different, where if you have to open transanorrectal, then for sure, I would vote against not having a colostomy, because the chance of having a fistula when you have a round anastomosis and a longitudinal anastomosis and the posterior sagittal incision with a normal sphincter, you must have a colostomy.
Somebody said that is much easier to be a historian rather than a prophet. Now, in retrospect, when you look at the anatomy of this case, you conceivably, you could have done this primarily. But without this diagram that we are looking at, to approach this patient primarily would be an adventure, because the surgeon would not know exactly the anatomy of the patient. Very bizarre anatomy. So that would be a misadventure. It goes against the interest of the patient.
Oh, and regarding the biopsy for Hirschsprung, I would say absolutely no need to biopsy Hirschsprung. The association of Hirschsprung and anorectal malformation is extremely unusual. So I don't even have a reason to justify a biopsy in this case. I would not think of Hirschsprung. This is a case of a complex anorectal malformation. So no need for biopsy.
Okay. Thank you so much. Just to finish, doctor, do you think will be important to dilate the anus past Regegatel?
Yeah, so in the picture, it looked like a normal anus. If it's a strictured anus, meaning if it is smaller caliber, a newborn should accept a number 12 Hager. So if it is a smaller anus, yes, I would do an anoplasty to make it adequate size. But you can just do a Heineck Mikulik, something very small, because it seems to be in the center of the sphincter.
Okay.
Unless the entire lower rectum is narrow. What Dr. Bishop said is applicable to a case of anal stricture, but it's a piece of rectum. If all that piece of rectum is narrow, you could give the patient the benefit of dilatations to see if that would grow.
Okay. Thank you, Dr. Peña. Thank you, Dr. Bishop.
Perfect.
You,
so then, thank you. There's another question, lap release of the fistula, then using a circular stapler or hand sew anastomosis. The lap release of a rectourethral bulbar fistula in a patient with hypospadia, it's not that easy. I'm not saying it cannot be done, but it's very low in the pelvis. And I would say very few surgeons have enough experience to do this very delicate dissection. So I would not suggest that approach. I think with the posterior sagittal, you have direct visualization and you can separate the rectum well from the urethra.
Laparoscopy? We believe that laparoscopy in anorectal malformations is particularly well indicated in cases of rectal bladder neck fistula. And rectoprostatic fistula, if you are skilled and you are good you were trained that way, perhaps you could repair the malformation successfully. In rectourethral bulbar fistulas, we consider seriously that the laparoscopy is contraindicated. We believe that based on our experience of receiving many cases in which the very optimistic laparoscopic surgeon tries to repair rectourethral bulbar fistula, they damage the urethra or they leave a piece of rectum attached to the urethra that becomes a posterior urethral diverticulum. In addition, the repair of a rectourethral bulbar fistula via posterior sagittal is one of the perfect indications with minimal mobilization of the rectum. When you repair a rectourethral bulbar fistula laparoscopically, by definition, you divide all the anchoring mechanisms of the rectum in the pelvis, and that explains why these patients have a high incidence of rectal prolapse. So when you repair a rectourethral bulbar fistula posterior sagittally, you only mobilize the lowest part of the rectum and leave the rest of the rectum attached into the pelvis, and therefore they don't have prolapse. So we now call, when laparoscopy is used to repair rectourethral bulbar fistula, we call it maximally invasive laparoscopic operation.
So there is one question, if anorectal malformation and Hirschsprung disease can coexist. Yes, they can, but it's extremely unusual. We only have 4 documented cases, but we have more than 70 patients that underwent biopsy unnecessarily just because patients with anorectal malformation have severe constipation. It is extremely unusual for a patient with anorectal malformation to have Hirschsprung, but yes, it can happen. But I would say, generally speaking, you should not even suspect of the combination. So I'm going to present the next case. This is a male patient that was born with several congenital anomalies. He had chromosomal anomaly, a core D in left hydronephrosis, a low-lying conus that on ultrasound, it was ending at L5, cleft palate, and low set of ears. Because initially the genetic malformation was found, and then with the genetic malformation, they decided to screen the patient for other anomalies. So here you can see the right kidney is a little smaller, and the left kidney has severe hydronephrosis and megaureter that it's not shown here. And in the spinal ultrasound, you can see that the conus terminates in L5. So because of that, in our hospital, whenever they are doing the spinal ultrasound, they mark with a radiopaque arrow where the conus is terminating. And I know it's hard to see here, but when you look at this x-ray, you can see that the patient has a sacral defect, and I have a better image. It's still not ideal, but here you can follow the edge of the sacrum, so you can see that the patient has a sacral defect. So the patient underwent MRI, so you can see that the conus goes all the way to L5, and then you find a lesion at the end of the conus. And from this image, I had the impression that this lesion communicated with the pre-sacral mass that was also found. So this patient was seen by neurosurgery, and then the neurosurgeon called me because of the pre-sacral mass. As you can imagine, we are very good friends with the neurosurgeon, but they don't like to operate with us because they are extremely concerned of contamination. So we decided that the neurosurgeon would do his portion first, and then I would do the pre-sacral mass afterwards. So here you can see just a few images, and here you can clearly see the pre-sacral mass. So the first question is, if you are called, I'm not going to say because I know I have a question about that, but the patient underwent detethering of the spinal cord and the cyst removal, the one that was attached to the conus, and it came back as a mature teratoma. So the question is, if you are called in clinic to see a patient with pre-sacral mass, what type of anorectal malformation must be excluded? And you have to remember, I met this patient, he was already 6 months old. So anorectal stenosis, rectoperineal fistula, all of the above, I don't know. So we have a very divided audience, which is fine. So this patient, you always have to think that there is a possibility of anorectal malformation, especially anorectal stenosis and rectoperineal fistula. Both of them could be present. So looking at the anus, the patient looked like a funnel anus. So I suspected he had an anorectal stenosis, but to my surprise, when I did the digital exam, the anus was completely normal. There was no anorectal stenosis. So after the patient had the neurosurgical procedure, I asked for another MRI in preparation for my surgery to make sure there was no connection with the dura. And then, unfortunately, during this next MRI, we found that the patient had an intra-abdominal lymphatic malformation, as if the patient didn't have enough anomalies. So since my portion was not urgent, I let them repair the lymphatic malformation, and they removed the lymphatic malformation. He did very well, and finally he came for the pre-sacral mass removal. You can see that it's still right there. Here is just showing the kidney that, and you can also see how this pre-sacral mass was really high in the pelvis because it's a patient with a very large sacral defect. So here is the appearance of a funnel anus. It almost looks like someone is pulling the rectum. So you see that instead of having a round, you see more like a straight line. And but again, there was no anorectal stenosis. So now the patient is in prone position. And as we here, I put 2 5/0 silks in the edge of the anus. We enter posterior sagittally. And because we have a good MRI, we know where we're going to find the pre-sacral mass. We place multiple 5/0 silk stitches and we dissect this mass. So here you can see the mass being dissected. I like to keep a hanger in the rectum to make sure the rectum is not open, but I do bowel prep in this patient so we don't have contamination. And then after the mass is removed, you can see that there is an empty space, but in this case, we were able to close it. If you see that you have a dead space, we recommend leaving a drain for that to heal. And here is the pre-sacral mass that was removed, and it came back as a mature cystic teratoma. So any questions or concerns about this case? Do you want to comment?
No.
So the only thing, this is a patient with a very complex genetic anomaly, multiple malformations. But if you see a patient with a pre-sacral mass, this is the patient that you should screen the family. That's the one we should get sacral x-rays for the parents, and we should counsel the family that the next child may well come with the same malformation. It's extremely unusual for anorectal malformations to happen in families, but the type of malformation that does happen in family is pre-sacral mass, anorectal malformation, and sacral defect, also known as the Currarino triad. We did 2 cases with neurosurgeons, no contamination concern. Well, congratulations. Usually our neurosurgeons don't like to operate when we are manipulating the rectum. In this case, I was not planning to manipulate the rectum anyway, but we decided to separate the procedures. Okay, if there are no questions or concerns, we're gonna move to the next case that will be presented by Dr. Juan Sobrado. Welcome, Juan.
¿De dónde?
Costa Rica. Juan, we cannot hear you. I see that you're still there, so if you can please connect your microphone.
Would you want to try to just reconnect your webcam for a second, Dr. Sobrado?
My name is pediatric surgeon.
Here we go. Come on back. Try again. We heard you for a second. We cannot hear you now.
So Juan, what I'm gonna do is I'm gonna start your presentation. I'll try my best, but you can interrupt me as soon as you get better connection. If you get connection, just tell me. I don't know if this is a post that we did about all myths and realities. Is that all anorectal malformations are diagnosed at birth? And the reality is, unfortunately, nowadays, still in the United States, malformations can be missed. And the one that is most commonly missed is the most benign one, the rectoperineal fistula. And the reason is the patient can stool at birth, and because sometimes some rectoperineal fistulas, for an untrained eye, it may not be super easy to diagnose. So the case that Dr. Juan would like to present is an 11-month-old female. I think she's from Panama, and there were no past surgical history. And I understand that the mother is currently pregnant again. She is still exclusively breastfed. She has loose daily stools and weighs 6 kilos. So I think Dr. Juan is in Costa Rica and the patient is from Panama. So there is the language barrier, there is the distance from the countries, and I'm trying to do my best with the presentation. So she was admitted to his hospital due to bronchiolitis, and during hospitalization, it was found to have scabies and anorectal malformation. So here you can see the perineum, and this is a case in which the diagnosis was not made because the doctors did not look. Juan, are you back there?
Juan, can you hear us? Can you say something?
I can see him, but you can all see that this is a case that if somebody had looked, the diagnosis would be made. Here, the urethra, the vagina, and the perineal fistula. It's very tiny, very close to the vagina, and the center of the sphincter is very obvious, and it's behind. So this is a case in which the diagnosis was not made because it was not looked. So the fistula is anterior to the center of the sphincter. The patient has a good gluteal crease. The fistula was calibrated with a Hager 8, and they were able to dilate up to a Hager 10. The abdominal ultrasound was normal, and there was no heart disease. So here's the abdominal X-ray. I cannot see the sacrum clearly, but I'm concerned that it may not be a normal sacrum. So I think the surgical options would be to operate in Costa Rica after the respiratory symptoms. There will be the challenge of family separation. There's a new baby that it's coming. How is bowel management gonna be? Other option would be no surgery, just dilation, or transfer to Panama and have the problems of border coordinations. So I think Juan is presenting a challenging because as pediatric surgeons, we are limited and it's very hard for us to solve social problems. So when we discuss rectoperineal fistulas, there are some rectoperineal fistulas that are feasible to just dilate. But the one that he showed in the picture, I think it's one that we would all agree that needs operation, because even if you dilate, this is very abnormal and very close to the vagina. The patient would be left without a perineal body. So I think this is one that I would advise for operation, and I would have a very honest conversation with the family, and if they can wait for the operation to happen, I think it would be a good impact for the future of this child. Do you want to comment?
You know, Juan, that's his name.
Juan. Mm-hmm.
Juan, my wife and Dr. Bishop and myself live in the United States, but we were not born in the United States. I was born in Mexico, and then I was born in Brazil. And I work under difficult circumstances in the early years. So please accept all the pediatric surgeons who work in the so-called developing countries. And by the way, it's in those countries where they have more cases of congenital defects. So please accept my admiration and respect, because you have to solve these problems and with many restrictions and many limitations. So we don't have an answer as to what to do in cases like this in terms of social and economical problems. We just have to respect your decision. You do whatever you can do only. And then you have to try to sleep, relax and sleep at night, but you only do what you can do. We admire and respect you. And a Spanish philosopher said, by the name of Ortega y Gasset, said, man and his circumstances. So the circumstances that surround each one of the members of this audience is different. Some people is in working under ideal circumstances and hospitals with equipment, material, resources, and some other people I'm sure is working under difficult circumstances. Here we only discuss what we would do, but under your circumstances, I don't know what I would do. You have to go, like I was in Mexico, and the problem sometimes was the follow-up of the patients. And what I did is to contact the Department of Police. And when a patient did not come to an appointment, I sent the police to bring the patient to the clinic because I thought it was very important for the patient. So I cannot do that in the United States, but in every place is completely different.
So any questions, concerns? I hope Dr. Juan Sobrado was able to listen to our comments. If you want to chat or if you want to call us later, we're happy to talk more. And we're very sorry that we couldn't, the internet didn't help us right now. So I think perfect, social geographical dilemma. I think Dr. Sunny Yamut wasn't able to connect, so I'm going to pass my case because I have another one that we can present in the last 9 minutes. And this is a case that, as Dr. Peña said, it's easier to be a historian than a prophet. And even in experienced hands, how we can be fooled. And the reason I'm presenting is so it doesn't happen to you all, the same thing that happened to me. So this is an 8-month-old female patient that was born with a cloaca that was described as a 2 centimeters common channel. So she called our center saying that she had a 2 centimeters common channel. We were extremely excited because usually surgeons don't refer the short common channel. They refer to us the most complex cloacas. So she underwent a diverting colostomy on day of life 2. But unfortunately, her mucus fistula was closed after surgery. So in preparation for surgery, what would you do? Open the mucus fistula to study the patient properly, do a pelvic MRI instead, do a cystoscopy to measure the common channel. And I think you are all answering very properly that we should have a better definition of the anatomy. So opening the mucus fistula to study the patient properly is an excellent option. And do a cystoscopy to try to measure the common channel is also a very good option. Because this patient was coming from out of state, we decided for one single trip. So we decided just to do a pelvic MRI and proceed with surgery. So here is the sacrum. The patient had a good sacrum, a normal sacrum, AP and lateral. Patient also has normal kidneys, mild dilation, no tetrachord. But when we looked at the pelvic MRI, first of all, I have no explanation why, but we didn't have a very good pelvic MRI, which is unusual for our hospital. But here you can see the bladder, that's the ovary, and here you can see the cervix. So that is one cervix and one hemivagina. And in another image, you can see the bladder. It's a very large bladder. And you can see both cervix here. So it's almost as if the vaginas are being pulled by something. And just to give you a hint of what that is, you have to see that here is the colostomy. So it's almost, remember, usually we have the bladder, the 2 hemivaginas, and the rectum entering in between the hemivaginas. So if you think that the rectum is being pulled, then the vaginas are in one side here. So on cystoscopy, we found a 3 centimeters common channel to a urethra and bladder. And the second structure, we were not 100% sure. It looked like it was the rectum, but we couldn't be 100% sure. But because we thought it was a short common channel, we decided to start posterior sagittally. We were able to find the urethra and the vaginas. We did a total urogenital mobilization, and the urethra and the vaginas reached the perineum. With a lacrimal duct probe, we try to look for the rectum, and you find that extra tissue behind the vagina, but there was absolutely no signs of the rectum. We tried, and there is a point that for the safety of the patient, you have to decide we should not keep looking, we should just go to the abdomen. We were not initially prepared to go to the abdomen, so we had to put a tegaderm, do a total body preparation, and then we open the abdomen. Once we opened the abdomen, we found the explanation why the rectum could not be found. The rectum was extremely high in the abdomen, and unfortunately, the surgeon that did the colostomy did it too distally. So this was the entire rectum. It measured 3 centimeters, and it had absolutely no blood supply. So there was no way for me to mobilize this rectum, because if I took it from where it was, it would simply die. So in this case, what we had to do, my first question to you is, how can this be avoided? There's no way to avoid it. Making the colostomy at the descending colon instead of low sigmoid, or I don't know. And everybody knows the answer, and it is so important to do the right colostomy when a patient is born. So that's correct. Making the right colostomy would have avoided this problem from happening. So we had to bring the proximal stoma as the neoanus, and here you can see I have the posterior sagittal incision closed. That's the anoplasty, the perineal body, and I'm not showing, but there is the vagina and the urethra. So what is not ideal in this case is because in the ideal scenario, we know the anatomy and we can talk to the family before the surgery about everything, the time of the operation, and including the future prognosis for bowel control. In this case, what we found during the surgery is that the prognosis for bowel control will not be good. Even if I was able, even if the colostomy was done a little better, this was a very high rectum, so I think the prognosis for bowel control was not good since the beginning. But when the patient loses that distal portion, then for sure the patient will not have bowel control. So that's something I had to inform the patient. In a good side, the family was very happy that the child does not have a colostomy, but it's not our ideal scenario. I think if the patient could have a colostomy, let everything heal, it's better in a patient with a cloaca. So any questions about this case, concerns, comments? And I think in retrospect, everything is easy. Even looking at the MRI, we should have suspected we were dealing with a longer common channel. And the message that I can tell is, as much as we love each other, we should never trust each other. You should always have a healthy question in your mind that whoever measured the common channel may have been wrong. So never trust a report. So even when it's someone that you really know, you should always doubt and think and double check for the benefit of the patient. So if there is any questions, concerns, comments, there was no connection between the rectum and cloaca. There was a connection, but it was very high in the vagina. So I could only find the rectum through the abdomen. If you imagine from the mucus fistula side, it was only 3 centimeters. So it was very high. And that's why in the MRI, you see the vagina towards one side because the rectum was pulling on those vaginas. So our next international, do you want to comment?
Yeah. So I want to repeat that in general, the repair of anorectal malformation should never be an exploration, should be a perfectly planned procedure. And therefore, it's important to have as much information as possible before we make our surgical plan. If in this particular case, I believe that you already mentioned that, you all mentioned that if the mucous fistula was closed, so our approach should have been open the mucous fistula and inject contrast material to have a complete image of what the anatomy of the patient was. And if that was done before, then this patient could have the patient did well, but could be a much better planned operation with no incidents.
There's a very good question from Dr. Zornosa. Did the patient have bowel preparation? This patient did not have a bowel preparation because I was not planning to go to the abdomen. So what I did is once we decided to go to the abdomen, I placed a packing gauze in the stoma. And then once I decided that I had to remove the proximal stoma, what we did is we removed still with the packing gauze. And then while we had the 5-0 stitches, we removed the packing gauze and we placed a stapler at the tip of the stoma to avoid contamination. So we were very, very careful. And I have to say, in this case, I was lucky enough that I did not have stool contamination during the case, but it's definitely not ideal. I am presenting this case because I felt I did not prepare correctly for this case. And when we give courses, I always advise everyone, when in doubt in cloaca, do a bowel preparation. So I think in this case, for sure, I should have done a bowel preparation, but I didn't do. It worked well. We were able to solve all the problems, but this is not the ideal scenario, for sure. So our next International Colorectal Web meeting is scheduled for December 16. I hope you can all join us, and thank you for joining us. From, again, I'm just going to mention the countries: Costa Rica, Peru, Dominican Republic, Colombia, Bangladesh, Russia, Haiti, Thailand, Greece, Kenya, Argentina, Sri Lanka, Philippines, Indonesia, Bahrain, India, Nigeria, United States, Italy, Egypt, Spain, Honduras, and Czech Republic. So thank you very much, and we hope to see you in December. Bye-bye.